This video is for the assessment of hip joint mobility. The scientific explanation of this technique is as follows. The hip joint is formed between the convex femoral head and the concave acetabulum and permits motion in all three of the anatomical planes of motion. The motions available at the hip are flexion, extension, abduction, adduction, internal rotation, and external rotation, all of which have the axis of motion passing through the center of the femoral head. Due to the composition of the hip joint, femoral motion is coupled with motion of the innominate at the end range of motion. So for full range of motion to occur at the hip, innominate rotation must also occur. In order to assess hip joint mobility, the therapist must not only assess the femur's ability to glide anterior, posterior, superior, and inferior, but also needs to assess the innominate's ability to anteriorly and posteriorly pelvic tilt. According to Newman's book on the kinesiology of the musculoskeletal system, the hip joint flexion is associated with a posterior inferior glide of the femoral head. Extension is associated with an anterior superior glide and is almost a pure spin in terms of arthrokinematics. Additionally, hip abduction is associated with an inferior glide of the femur within the acetabulum. Hip internal rotation is associated with a posterior glide, and hip external rotation is associated with an anterior glide of the femoral head in the acetabulum. At the end range of flexion, the innominate must rotate posteriorly or undergo a posterior pelvic tilt. And at the end range of extension, the innominate must rotate anteriorly or undergo an anterior pelvic tilt. In order to adequately assess hip joint mobility, the clinician must assess the hip's ability to produce these glides, as an inability due to a variety of different reasons will have a large impact on hip joint. In order to explain this in layman's terms, I would say it as follows. I will be looking at how your hip is moving as a joint and looking to see if your bones are able to move past each other appropriately enough to produce normal motion. So step-by-step instructions for the assessment of hip joint mobility start with, these techniques will be done on both sides of the body, but if the patient presents with a symptomatic side, you'll perform these on the asymptomatic side first. First motions to be assessed are done passively while palpating the anterior superior iliac spine for flexion or the posterior superior iliac spine for extension to assess the innominate's ability to anteriorly and posteriorly pelvic tilt, as this may be the limiting factor of joint range of motion. So the first step is to have the patient come and get into supine. So you're going to place the patient in supine, have her straighten out her leg, and then what you're going to do, go ahead and bend this other leg up. First, you're going to palpate the anterior superior iliac spine, which is right here. Then I'm just going to passively bring Sarah's leg up into hip flexion. Looking for that posterior rotation of the innominate. We're going to have the patient lay prone, and we're going to assess hip extension, looking at when her posterior superior iliac spine drops away from our finger. So the first step is to go ahead and palpate the posterior superior iliac spine. I'm going to pull her hip into hip extension and take note of that posterior superior iliac spine moving away from your finger, indicating an anterior pelvic tilt. Next motion we're going to check is hip joint distraction. So for this one, the first step is just to place the patient in supine with a gaiter or mobilization of belt, just tighten down across her anterior superior iliac spines. It kind of helps provide some stability so we get a better sense of what's going on. The next step is I'm going to come in and I'm going to get Sarah's leg just up in the 90-90 position with her leg just resting over my shoulder. I'm going to come in with my hands, get as close to the joint line as possible. And then with, just going to come here, I'm just going to pull straight down in the inferior direction. Next motion we're going to do is we're going to get a posterior glide, which is associated with hip flexion and internal rotation. So the first step for this is you're going to want to place the patient in supine, and you're going to get them to flex their hip into 90 degrees of hip flexion with a mobilization belt as close to the joint line as possible. We're going to get her up 90 degrees of hip flexion. I'm going to let the knee just passively flex. Then what I'm going to do here is I'm just going to use the mobilization belt to provide a little bit of gentle distraction, and then pressing down on the top of the knee, just going to lean into it and assess that posterior glide of the femur and the acetabulum. So again, gentle distraction, leaning into it, assessing posterior glide. Last motion we are going to be assessing is an anterior glide, which is associated with extension and external rotation. So the first step is you're going to place the patient in prone with a tower roll placed about halfway down the anterior part of the thigh. Tower roll there. Second hand is you're going to place one hand underneath the patient's knee. You're going to bring them passively into a little bit of knee flexion. With the other hand on the posterior femur, as close to the joint line as possible. And all you're going to do is just kind of gently distract with the hand just above the knee, and just to lean into it and apply that anterior force, looking for the ability, again, of the femur to glide anteriorly within the acetabulum.